afternoon and welcome. I am Derik, Dailey. I'm excited to be moderating today's panel on healthcare as a moral imperative, a faith and human rights perspective. You know, in the era of COVID-19, who gets testing and treatment and at what cost? The global coronavirus pandemic has heightened the urgency of critical, long-running debates about healthcare access and affordability in the United States. The current public health and economic crises are laying bare in very real ways the failures and inequities of the US system, and at great human cost. The shared wisdom of diverse faith traditions make a compelling moral case for meeting healthcare needs, regardless of wealth, regardless of employment or social status. And similarly, access to healthcare is widely recognized as a basic human right under international law. Today, two experts join me to explore the healthcare crisis in the United States, the human right to health, and how communities of faith can advance this right in an hour of great need. First, Professor Fran Quigley, founder of Faith in Healthcare and professor of law at Indiana University McKinney School of Law, where he directs the Health and Human Rights Clinic. And second, Allyson McKinney Timm, founder and executive director of Justice Revival, a community of faith dedicated to serving as a Christian voice for human rights in the United States. Allyson is a theologically trained human rights lawyer and served as a Lowenstein Fellow in International Human Rights Law at Yale Law School and as director of the Uganda Field Office of International Justice Mission. We are so pleased to welcome both of them today. Let us get started with Fran as he delves into the current healthcare crisis in the United States. Fran?
Thank you, Derik, and thank you to you and to Allyson and to everyone at Justice Revival for putting on this webinar, and everybody for joining us today. It's a real pleasure and a privilege to be able to talk about this difficult, complicated question, but also enormously important. So in talking about the US healthcare crisis, there's a couple of different ways you can do so. One is to talk about data, and I will mention that. There's some really disturbing numbers out there. Some of you may know these disturbing statistics, but Justice Revival is devoted to human rights. Faith in Healthcare is devoted to human rights. My guess is most of you joining us today are devoted to human rights. And the first word in that phrase, of course, is human. So let's talk about, to start, the human cost of what we are enduring here in the United States. This is a picture of Nicole Smith Holt. Nicole and her family, her husband James, are folks that we've come to know in our family and have stayed with us in Indianapolis where we live. Nicole's holding a picture of her son Alec Rayshawn Smith. A few years ago, in 2017, Alec turned 26 years old. Now, many of you listening to us today know that in the United States healthcare system, the way we set it up right now, the 26th birthday is a really important one because it's quite often where young people will be aging off of their parents' health insurance then. And it's also quite often the case where the parents' health insurance tied to their employment, the way we do that in the United States, is actually much better than the young person's access to insurance. That was true for Alec too. Alec worked full-time, worked at a job as a restaurant manager, did not have access to good health insurance. Before he turned 26, he and Nicole understood the significance of that birthday because Alec was a person with type 1 diabetes. And a person with type 1 diabetes, folks on this call probably already know, are people who do need insulin each and every day to survive. And so they understood how important it was that Alec not have a break in his coverage, that he does have access to his insulin. Some of you may know also the price of insulin has skyrocketed in recent years. A vial of insulin that costs about $5 or $6 to manufacture can cost as much as $300 per purchase. For a person with type 1 diabetes like Alec, that can mean a bill of as much as $1,000 or more per month just for insulin alone. So they understood how important this was. They did their shopping, they did their due diligence, and found that the best health insurance that Alec could get in the United States healthcare system would have cost him $450 a month for a premium. That's a lot on a restaurant manager's salary, but Alec was ready to pay that. He was ready to figure out how to afford that. But that wasn't all that was going wrong with that insurance policy. Again, the best they could find. Also had a deductible of $7,600. $7,600, which meant that Alec would never get any benefit from the health insurance he was paying. And this is pretty common for a lot of folks, especially young people who are working, until he paid all of that money out of pocket. So Alec made a decision. He wanted to be independent from his parents. He wanted to keep the job, but maybe look for a job with some better health insurance, which is hard to find even before the pandemic. So he did that, and he decided he'd pay for his insulin out of pocket. But what happened was when he went to the pharmacy, the price of insulin had gone up yet again. The price for 1 month was $1,300 for a month's worth of supply of insulin for Alec. He couldn't afford that. He couldn't afford health insurance. So he made a decision that 1 out of every 4 persons with type 1 diabetes in this country make, and that is he decided to ration his insulin. But for a person with type 1 to ration their insulin is an incredibly dangerous act. And the reason Nicole is holding a picture of Alec and not holding Alec is because he passed away on June 27th, 2017 from diabetic ketoacidosis because he couldn't afford the medicine and he couldn't afford the health insurance to cover the medicine that would have kept him alive. Now, this is a tragedy, of course, and it's a tragedy that I happen to know the family, but it's not uncommon. It is not at all uncommon. We could tell other stories. Sarah Broughton, a young woman of 20 years old only, no pre-existing conditions like Alec had. In California, she didn't have health insurance, like a lot of our students at our law school don't have health insurance. She had a sinus infection, decided not to go to the doctor. It got worse, couldn't afford to go to the doctor. Finally, it got so bad she was taken to the emergency room, but it was too late. And Sarah had the infection had spread to her brain and she passed away. So we tell these stories before the pandemic, but then since what we've seen in the last couple of months is that 27 million people, according to the Kaiser Family Foundation, a recent estimate, have lost their health insurance because they've lost their employment. 27 million people in this country are going to be facing what Sarah faced, what Alec faced. CBS News recently interviewed a man, a father of 4 in Kansas, Chris Jump. He has diabetes. And he said he was worried that he wasn't going to be able to pay for both insulin and for food for his children. And he said this, diabetes almost killed me 2 years ago, but I'm not going to tell my child, hey, you can't have any spaghetti tonight because dad needs insulin. No, that kid's going to get a meal until dad's laying in the ground, is what he told CBS News. And that's not an exaggeration. Physician researchers, and we can see this in the next slide, a little bit of zooming out here, is physician researchers have shown that we lose tens of thousands of people who lose their lives in this country. Don't just suffer. Millions of people suffer. Tens of thousands of people each year lose their lives because they can't afford medicines, because they can't afford health insurance. 2/3 of people are skipping treatment each year because they can't afford the care. 1 out of every 4 people who are adults in this country are carrying past due medical debt. It's one of the leading causes of bankruptcy. 20 million people, according to a recent University of Chicago survey, 20 million people in this country have gone on GoFundMe or some other begging crowdfunding website to try to get healthcare for themselves and for their families. So I would suggest to start off this conversation today that what happened to Alec, what happened to Sarah Broughton, what's happening to so many other people in this country, we're beyond the title of this portion of our webinar as a healthcare crisis. I'm suggesting that we're in the middle of a moral crisis. We're in the middle of a moral crisis, and that today, when we talk about what faith communities have to say about healthcare, I think is the question is, what does our faith tradition, any of our respective faith traditions, call for us to do in response to this moral crisis? So I'll turn it back over to Derik.
Fran, in light of the stark data that you've put forward, and I think what you've aptly framed as a moral crisis, I want to direct our participants to really reflect on the question on your screen. What action does your faith tradition call you to take in light of what you've heard with respect to the healthcare and moral crisis in the United States? Again, what action does your faith tradition call you to take? And as you're reflecting, I invite you to respond in the chat box on Zoom at the bottom of your screen. Again, what action does your faith tradition call you to take? And as you're reflecting and inputting your responses in the chat box, I'll ask Ally to share a little bit about her faith tradition's response to healthcare and the current healthcare crisis. Ally?
Well, the stories that Fran shared cut straight to the heart. Those are terrible tragedies, and I think it's pretty impossible to hear those stories without feeling grief for the mothers, the families who have lost dear ones after trying to do everything they could to find affordable, accessible healthcare. I want to share some of the wisdom that comes from my particular tradition, which is the Presbyterian Church, from my denomination, and what they've said on this matter. As followers of our great physician Jesus, we have a moral imperative to work to assure that everyone has full access to health care. We're warned by the prophets not to heal the wounds of God's people lightly, yet in 2006, aggregate profits of health insurance companies in the US were $68 billion. In that same year, more than 15,000 families forced into bankruptcy due to medical expenses. So the Presbyterian Church USA adopted a recommendation in 2008 calling for education and advocacy to advance the goal of a single-payer universal national health insurance program, which it assessed best responds to the moral imperative of the gospel.
Thank you, Allie. And I just want to note, many of our friends are responding in the chat box, and I want to lift up a couple of the responses to the question, what action does your faith tradition call you to take? One of our friends said that her faith tradition calls her to educate people on the complexities of the inequities within our system, and then learning as much as she can to identify practical options for moving public policy forward here. Someone else says that her tradition calls for civil disobedience. And another says to develop local and ecumenical programs that help educate and to support these really, really important public policy positions. All of those are so important. And our hope today is that you'll get some insight on how these two organizations can assist in that regard. So keep the responses coming in the chat box, and our hope is to respond to those throughout the presentation. I'd like to turn to the other aspect of this webinar, which Allie is uniquely positioned to talk about, and that is the international human rights lens. And so I invite Allie to speak a little bit about international human rights commitments for health, as we're thinking broadly about the current health and moral crisis in the United States.
Thank you, Derik. So I'm going to offer a brief high-level summary of some of the foundations for international legal commitments to health, as Derik said. And clearly, we've already talked about faith dimensions of a moral obligation, and now we're going to look at the legal obligation that the United States and other governments have under human rights law. So first, the WHO. You've probably heard quite a bit about it during the COVID-19 pandemic. It's a specialized agency of the United Nations. It has responsibility for coordinating international health. It has been around since 1948, and among its many functions and duties in the promotion of the highest attainable standard of health for all people globally, among its duties are coordinating responses to epidemics like the one that we're currently witnessing. It's important to note that the WHO has its origins in work to eradicate infectious diseases like polio and smallpox. So that's really a core function, a core competency of this agency. The WHO has a constitution, which is actually an international treaty agreement, which the United States joined again in 1948 at the founding of the WHO, meaning the US took on binding legal obligations by fully joining and accepting this WHO constitution. One of the key principles mentioned in the Constitution's preamble is indeed that enjoyment of the highest attainable standard of health is a fundamental right of every person everywhere without exception or distinction. That means the US acknowledged the responsibility of the government to take all reasonable measures over time to progressively realize this human right to the highest attainable standard of health. The WHO's work is guided by a shared commitment to creating a world where, and I quote, all people everywhere have access to quality and affordable health care. So the WHO set a goal of ensuring 1 billion more people universal health care coverage by 2023. So again, the US is part of this treaty, acknowledged the human right to health, and with this, the fact that access to affordable care is essential in realizing that right. Now, I'll talk again just briefly about the International Bill of Rights. The cornerstone is the Universal Declaration of Human Rights. This document, a signal, uniquely authoritative cornerstone of international human rights law and really the beginnings of the modern movement for human rights. And the Universal Declaration, likewise, ensures a right to a standard of living adequate for health and well-being of oneself and one's family. And this includes, again, I quote, medical care and necessary social services. So this declaration is one component of the International Bill of Rights. The others are 2 other international treaties, very special treaties that are referred to as covenants. The one on the left talks about the civil and political rights that we know best from our US constitutional system, and the United States is a full participant in this treaty. The treaty on the right talks about rights that are considered economic rights, and the US signed this treaty. President Jimmy Carter signed it, but the US Senate has never ratified it, and it won't come as a surprise to hear that economic rights, like the right to health, education, work, are more politically contested in the United States. So key to recognize that the US is a full participant in only half of the International Bill of Rights, something to think hard about given the situation we're seeing now. But still, it has obligations regarding the right to health. And I'm going to talk about its obligations under a few different treaties. The Civil and Political Rights Treaty includes a right we know from our Declaration of Independence, the right to life, very important, central in human rights law. I'm using it not in the colloquial vernacular way it gets most often used in the US, but in the technical legal understanding of this right. And it means governments have an obligation to respect life. So this points against the death penalty, for instance. It prohibits anything like summary execution, but it also imposes rights to affirmatively protect life. And so the authoritative interpretation of this right has spoken to obligations of a government like ours, who is a full part of this treaty, to reduce infant mortality, increase life expectancy, and to eliminate epidemics. It also means that when the government takes someone into detention, it becomes responsible for the care of their life while in detention. So some national courts, India for instance, have looked at the right to life in their constitution and have adjudicated that that implies also the right to health. That's our focus today. That Treaty on Economic Rights that the US has signed but not ratified, it elaborates in greater detail the right to the highest highest attainable standard of health. It has a whole article that looks at this. And this right includes, for instance, availability of needed medical facilities, personnel, medicines. It also includes accessibility, including economic accessibility. And crucially, it specifies that this right should be afforded on a basis of equality and non-discrimination. That means no discrimination based on race, based on gender, based on disability, based on health status, for instance. No discrimination of any kind in whether someone is able to have their right to health realized. So the question here on this treaty, this economic rights treaty, is should the US not be part of this? And are we not seeing during this pandemic why commitments like this are important? And again, I think you see how closely interwoven the right to life and the right to health are, showing that all human rights are interrelated and indivisible, though we might speak of them as two different categories, civil and economic. It's really not possible and not desirable to separate them out in that way. And then lastly, I'll mention another very important core human rights treaty that the US has fully joined. It's the Treaty on Eliminating Racial Discrimination. The acronym is CERD. The US ratified this in 1994. And it obligates the US to eliminate racial discrimination in its many forms in law and in practice. And I'll simply note for today that Article 5 of this treaty talks about ensuring all people can enjoy their human rights free of racial discrimination, including, and I quote, the right to public health, medical care, social security, and social services. Of course, we know that a number of studies have documented widely disparate impact of COVID-19 based on race. The CDC tells us about 30% of people infected with COVID-19 are African American, compared to just 13% of the population. And we know Native populations, as well as Latino and Asian American populations in some areas are disparately impacted by COVID as well. So again, that's a brief high-level overview of some of the legal foundations in international human rights law for a human right, a universal right to health and by extension access to healthcare, which are relevant to us in this country, notwithstanding the debates on the issues or the ways in which various rights are still contested. And so with that,
I'm just going to say, Ally, it's really helpful to hear you talk about this international human rights lens and to ground the work that you're doing and Fran's doing in international law. But there may be some in our communities, and I suspect maybe some of the participants may be thinking of their own communities, and there may be some there who say, why should we look to international law? Why do we care about these treaties and these global international bodies? How might you respond to those communities or those individuals who may be wondering, what's the utility of international law for our work in our local community here in the United States?
Mm-hmm. We need the accountability. It provides additional tools to advocate with our national government, even with state and local governments, and to seek to hold our leaders accountable, because we know we have not only a moral basis, but some binding legal bases to require the government to respect, protect, and fulfill these rights. It may feel like a roundabout route. It would be great if the government just listened to citizens when they said, we need these rights respected. But we know from history that there is power to both international pressure, international consensus on some of these issues, and there is a watchdog and oversight role with each of these treaties. And just a quick example, So the CERD Treaty on Eliminating Racial Discrimination, like all human rights treaties, there is a committee that oversees implementation of this treaty. And so it reviews the US human rights record on race every 4 years, although this administration, I believe, missed its deadline quite some time ago for reporting to this treaty body. But in its most recent report in 2014, the CERD committee encouraged the US to take measures to ensure all individuals have effective access to affordable and adequate health services, with particular attention to racial minorities, undocumented immigrants who've only been in the country a short time. And it urged the US government to ratify the Economic Rights Treaty. And so you essentially have a group of experts in a subject area hearing from domestic US civil society about what people are really suffering on the ground, applying the legal standard, and then going back to the US government and saying, you haven't met your obligation in these ways. That then gives advocates a blueprint for advocacy for the next 4 years.
I appreciate that, Ally. That's really helpful. We're continuing to receive comments from our participants. One of our participants noted her desire to ensure that folks have access to healthcare, which comes outside of her faith tradition, but rather the human responsibility that we all have to one another. I think that may be a good segue, Fran, into your section here about multi-faith commitments to healthcare for all, and then for you to sort of queue up what we can do to make progress on this really important topic.
Thank you, Derik, and thank you, Ally, for framing this on the international obligations as well. And these comments are terrific, really inspiring, but also not surprising, because we have had the privilege in Faith in Healthcare for the last couple of years now to be reaching out and talking with folks who are either direct providers of healthcare or advocates for healthcare access from a variety of faith traditions. And it's this commitment to take action, to not be accepting of the moral crisis that we're engaged in here in the United States, we're enduring here in the United States, that cuts across all faith traditions. Most folks in the United States come from a Christian tradition. The Christian tradition, of course, has the Good Samaritan parable, which guides us and tells us that we have an obligation to provide care for the stranger, for the folks who are suffering. In fact, Jesus in the Gospels committed so many acts of healthcare that in the early church, he was often known as the great physician, and a great physician who never charged a copay, right? But that's, of course, something that cuts across other faith traditions as well. In the Torah, it's very clear that folks from the Jewish tradition have the same mandate to provide care and to advocate for others getting access to care. Same with the Quran, same with really all Holy Scripture. And so we've had this privilege in Faith in Healthcare for the last couple of years to talk with some of the folks from these different traditions. We've talked with Will Cook. Will Cook is an evangelical Christian physician in Southern Indiana who cares for the poor and the addicted and folks who are infected with hepatitis C and HIV. And he says he does so because he's inspired by the Sermon on the Mount to do that. We've talked to Arshia Wajid. Arshia Wajid helped found American Muslim Health Professionals. There are dozens and dozens of free Muslim-led health clinics that provide care for people from all faith backgrounds all around this country. And they do so because that's what the Quran, especially the idea of zakat, mandates that they take that action in their faith traditions. We've interviewed and talked with David Green. David Green's a physician in Detroit, and he comes from the Jewish tradition, and he says that tikkun olam and then the lessons of the Torah are what tell him that it's important for him not just to provide care, but to advocate for folks to get access to the care they need. And my guess is that you all are very aware that there's already a lot of charity going on from faith traditions. There are healthcare clinics and hospitals that are faith-led all over this world. As it turns out, the first ones ever, the first charitable hospitals were Islamic, but of course the folks in the Christian tradition and the Jewish tradition, the Buddhist tradition, et cetera, have followed in that path. But I think it's also important for us to talk about today that charity has not been enough. We do have millions of people without care in this country. We do have tens of thousands of people dying in this country for lack of care. And so we've had the chance at Faith and Healthcare to talk about advocacy with many of these folks from different traditions. So one of the most inspiring responses we received from Reverend Jimmy Hawkins. Reverend Jimmy Hawkins is the Office of Public Witness Director for the Presbyterian Church USA. And here's what he said. He said, charity is great, but, quote, Jesus did advocacy. Jesus challenged the system. Jesus said there were problems with the system. He told the Pharisees, you pay your tithes, but you neglect the weightier matters of the law, justice, mercy, and faithfulness. Reverend Hawkins said charity is okay. And frankly, we heard this from folks from the Jewish tradition and the Muslim tradition time and time again. Quote, the need is too great for individual churches to meet. Therefore, we need to be advocates for justice. For justice. And when Reverend Hawkins speaks this way, and when Dr. Green speaks this way, and when Arshia Wajid speaks this way, they do so firmly within their faith traditions in terms of advocacy. I have the privilege in my job at the law school of teaching about human rights movements. And when you look at human rights movements, you see a common thread going through all of them. We're talking about the civil rights movement, the abolition of slavery movement, the anti-apartheid movement, you name it. Faith communities have always been at the core of those movements, always been the ones providing a moral voice and saying that we need to do better, we must do better. And as it turns out, that's actually true in healthcare as well, not just with the advocacy that folks are doing, frankly, not yet to the place where we need to be in the United States, but in countries that do better. And I'll speak specifically about Canada. Folks probably on this call know that the folks north of us, our neighbors to the north, do have universal health care guaranteed by the government. And they may also know that the quote unquote father of the Canadian healthcare system was a politician, elected official named Tommy Douglas. What you might not know is how Tommy Douglas came to this issue. Tommy Douglas was a Baptist minister. Tommy Douglas was raised in the social gospel tradition, and he mobilized the faith community, the diverse faith community in Canada, to push for their universal healthcare system that they have now. And here's a quote from Reverend Douglas, who became Premier of Saskatchewan in Canada. Quote, we don't step out the front door into the kingdom of God. Instead, we slowly and painfully change society until it has more of the values that emanate from the teachings of Jesus or from other great religious leaders. That philosophy helped him and other faith leaders in the country of Canada to create their universal healthcare system. And we can talk about it in the Q&A, and you may hear some myths about the Canadian system. It's not perfect, no system is. But I will say this, two things. One, Canadians are very proud of it. Tommy Douglas is routinely cited as the most important Canadian of all time. Canadians say they're most proud of their healthcare system, even than anything else in the country, including hockey. If you know anything about Canada, that's a little bit of a surprise, but they even rank the healthcare system above that. And secondly, although it's not perfect, let's be real about this. In Canada, Alex Smith wouldn't have died. In Canada, Sarah Broughton wouldn't have died. These parents grieving their children who should not have gone to their maker would not be doing that in a country that does guarantee universal health care for all. They wouldn't be requiring people to do the online equivalent of putting a jar out by a gas station counter and say, please, here's my picture, please donate your spare change so I can have the surgery my doctor says I need. That's not heard of in that country. And what the faith community advocates that we've interviewed said is that what they consider their healthcare system in Canada to be is the Good Samaritan writ large. The Good Samaritan writ large. So as Derik invited me to as well, is just talk a little bit about what can be done. And this, some variation of this map is something that we teach in our health law program at our law school. And when we talk about the healthcare systems, is some variation of this map. And you've probably seen something like this. As you can see, most of the world is, most countries in the world are green. Those are countries that have free and universal healthcare. That includes Canada. It includes all of Europe, essentially. It includes almost all of South America. And there's a few countries that are red. Most of those are very poor countries that can't afford universal health care. But the red country is also the United States of America, right? The United States of America. So the question kind of becomes, well, why do we have a system in the United States like this when you look at, we actually pay more money in to our healthcare system than any other country, not just in the world now, but in human history. Per capita, we put more money into our healthcare system. But not only do we not have universal care, we have the worst outcomes of any other economically advanced country. And by worst outcomes, let's not be public health abstract about it. When we talk about maternal mortality, we're talking about moms dying. When we talk about infant mortality, we're talking about babies dying. When we talk about disparities due to income, we talk about the people who are poor, people who are lower middle class. In our country, they die earlier. They live sicker lives and they die earlier, sometimes as much as 10 or 15 years on average earlier than people with money. So how can that be? If we can look at another slide, I'll give you just a very broad overview of what other countries' systems look like. And it's a pipeline metaphor where you can see that they very simply, we're talking about Japan or Canada or the UK or Germany or what have you, they put their money in on the front end for healthcare, and on the back end of the pipeline, they get healthcare, right? Well, compare that to the United States, where we put more money on the front end than any other country in history for our healthcare, but we've got these poor outcomes on the back end. And why is that? Because we've got a big gaping hole in our pipeline, a big gaping hole that no other nation has, which is that we have allowed corporations to make money, a lot of money, billions and billions and billions of dollars off of our healthcare system. And we are paying for things like an $84 million a year salary for health insurance company CEOs, a $47 million a year salary for pharmaceutical company CEOs. We're paying for corporations to market. We're paying for corporations to process and deny claims. We are paying for them to gather profits for really, frankly, a very wealthy sliver of Americans. And that's why we don't afford good healthcare on the back end of a pipeline where we put more money in than anyone else does. So it's important to recognize that there's a lot of discussion and pushback of the idea of us having a universal healthcare system in the US, because it makes sense. If you are the beneficiary, if you're sitting in a corporate suite and you're the beneficiary of the hole in this pipeline, well, you want to keep it that way, right? There's a lot of people with a lot of vested interest in keeping the system in the United States as broken as it is. So you'll hear some myths out there, and we can talk about in the Q&A if you'd like to, and there's going to be some suggested reading, but some of it is, oh, we couldn't have possibly afford a universal healthcare or Medicare for all type system in the US, when in fact other countries achieve universal care for much, much less than we pay. You'll hear folks saying, oh my goodness, we couldn't possibly do this because we're going to have our care rationed. Well, my goodness, care is already rationed in this country. Ask the family of Alex Smith, ask the family of Sarah Broughton how care is rationed in this country of the tens of thousands of people who lose their lives each year. And oh, what if we have a Medicare for all type system? Well, we're going to have a lot less choices in our providers. As it happens, our neighbors in other countries who do follow the international law that Ally talked to us about, who do have a universal care system, they will typically have a Medicare type card that allows them to go to any hospital they want, to any provider that they want. And they can go and have much more choice than we have in our private health insurance system. So we can talk more about that. But there's a lot of studies, there's a lot of data, and some of the suggested reading will get you to that. But the bottom line is this: we know we can do this because all of those other green countries do it. All of those other countries provide universal care, achieve their human rights obligations, achieve their moral obligations for paying less money than we do, but they plug up this hole in the pipeline that you see here. So let me conclude my part with saying this. If you look at the moral crisis in healthcare, and you certainly have said that with your responses, we know that doing nothing is not an option for us. And I want to conclude my remarks with some optimism. I think there's 3 reasons why we should have some real excitement about the prospects for what we can see in our healthcare system in the next couple of years. There's 3 reasons to think that we have an opportunity to make a big change. The first is just where we live. We do live in a democratic system. We do live in a system where our elected officials will do what we say if enough of us say it, right? It may seem very difficult that we're going to overcome health insurance lobbyists or pharmaceutical industry lobbyists or misinformation campaigns or what have you. But it once seemed impossible to abolish slavery, right? It once seemed impossible to achieve civil rights. It once seemed impossible to women to be allowed to vote, right? We have seen impossible challenges be overcome with advocacy, and that's why it's so exciting to have this conversation today. So that's the first reason. The second reason is where we are right now. We are in a time in our history, certainly in all of our lifetimes, where the boiling point of the moral crisis for access to healthcare, 27 million people losing their health insurance in the last few weeks alone. We are at a boiling point. Even before the pandemic, a majority of Americans said we need a Medicare for all type system. A majority of physicians said we need a Medicare for all type system. A majority of nurses have said that. A majority of healthcare executives even have said that. And those numbers have even gone up, have only gone up and up and up since the pandemic has started. This is a moral crisis that's reaching a boiling point. This is an opportune time in history. I do have this opportunity to teach social movements, and sometimes it takes a tipping point. Sometimes it takes a crisis to see real change. And the third point I'd like to make in terms of why we are at this point where we have an opportunity is, for most of us on this call, we have a community. Most of us, maybe we have friends we're only seeing, unfortunately, by Zoom calls and social media for the moment, but hopefully soon we'll be able to see each other in person more. But in the meantime, we can communicate. We can communicate with our friends. Many of us are members of faith communities, and faith communities have always played an important role in making a change. And when we talk about what the Presbyterian Church USA has said in terms of, and what Ally pointed out, what her faith tradition has mandated in terms of access to healthcare, that is not an outlier. We see it across all kinds of faith traditions. And so one of the things we'll ask you to consider is to look and see what your faith tradition says about universal healthcare, what your faith tradition even says about single payer Medicare for all type system as a path to achieving universal healthcare. And my guess is, and we'll have that resource provided for you, is that your faith tradition has already taken a stand on this and said this is the morally right thing to do. And that gives us a chance to connect with and advocate within our communities. So let me close just by saying this. I appreciate the chance to talk with you because although today it is too late to save Alex Smith. Today it is too late to save Sarah Broughton. But there's millions of others at risk, millions upon millions of others at risk in this country right now. It's not too late to save them. It's not too late to follow our faith's core principles, and it's not too late for us to raise our voices and demand that the morally right thing be done, and that we actually finally look straight in the face of this healthcare crisis, and we, in the United States of America, finally make it stop. Thank you.
And I want to just build on that resounding, compelling cause to action that you shared, Fran. We've talked today about how there is a universal human right to health, which the U.S. has recognized through its international legal commitments. And as one participant astutely recognized in our chat panel, having an international human right, that is not the panacea, that is not the end of the road. But as Fran mentioned, as citizens in a democracy, we can take that tool of a globally sanctioned human rights standard. We can take the tools that oversight of our human rights obligations afford, and we can raise our voices together to insist, in the age of COVID, finally, that our government do what's needed to promote the highest attainable standard of health, and that means ensuring all people have access to affordable healthcare, regardless of their employment, regardless of their wealth, regardless of anything except their fundamental humanity. At the end of the day, that is what it means to have a human right. I will just add briefly, because we want to get to your questions. There are a few other things that you can do to follow up if you want to learn more, if you want to take action. I'll post links in the chat box to an article Faith and Healthcare has on its website, where you can research where your tradition or denomination has come out on the issue of universal access to healthcare. I also highly recommend you subscribe to the Faith in Healthcare weekly newsletter. Consider subscribing to Justice Revival's newsletter on our homepage. And again, we'll provide all these links. And if you want to know more about the issues we've been discussing, consider bringing Justice Revival to your community for our full 7-session course, Human Rights in Christian Perspective. And with that, I think now we have time for questions and answers.
That's right.
And again, you can use the chat box.
That's right. Thank you so much, Fran and Ally, for what I think has been a really, really informative session. As Ali said, we want to hear from all of you. We're so grateful that so many of you have joined us this afternoon to really go deeper and to think about human rights and healthcare. And so we invite you to begin to input questions that may be on your mind. There may be comments or thoughts that came to mind as you listened to both of our experts today. I'd like to hear those and pose them to both Ali and Fran. We've got about 10 to 15 minutes. So I will begin asking some of those questions and encourage you to keep them coming in as we enter into this Q&A portion. One question, Ali and Fran, came from a participant who really sort of cuts to the heart of the matter. You know, aside from the electoral piece, this human to human obligation that we have. She says, isn't Sunday morning still the most segregated hour in America? As such, how do we move mountains, in this case, nonpartisan or big public policy mountains or barriers, to encourage those of all faith backgrounds to recognize the need for healthcare for all? How do you do it in such a polarized, partisan environment? Ali or Fran, either of you want to respond to that?
I think you're muted, Ali.
Thanks, Derik. I'd love to jump in on the legal side, and I also look forward to hearing Fran's thoughts. Sometimes people object to the idea of a universal human right, like the right to health and healthcare, by saying, isn't that too sweeping and grandiose? Isn't that too difficult? But we know that one aspect that's prioritized in human rights law is equality and non-discrimination. So we're talking about equity and how healthcare services are afforded in the United States. And we are seeing just these extreme inequities. So from a legal standpoint, the priority under human rights law is on ensuring that those who are most vulnerable, most marginalized, and who are suffering the relative inequity the most, that those needs should be prioritized. And so that's one response that we can bring to raise people's awareness, their consciousness of, again, what's widely been agreed on globally as just the very basic things we should be doing as a society. And the immense challenge of addressing structural racism that this question raises, we know, is the deep work that needs to be done in America across a number of issues. And so we really need every tool that we can to do that. And human rights just brings us one additional tool.
Thanks for that, Ali. Fran, any thoughts on that?
I think that Ali said it. The one suggestion in terms of a pretty concrete way to try to address this enormous challenge that the questioner brought up is that there's been a few communities who have done in person what we try to do on the pages of Faith in Healthcare, which is to convene a multi-faith conversation about access to healthcare. And so it's really a remarkable event when you see, and it sounds like the start of a joke, right? You got a rabbi and an imam, and you got a priest, and you got a nun, and you got a monk, and you got a Buddhist a monk, and all these folks getting together. And if they talk about access to healthcare, we find that there's this complete agreement on what we're morally obligated to do. And it's one of the ways to bridge. We do go to our separate places of worship on the weekends, on Friday, Saturday, and Sunday. But bringing folks together specifically to talk about healthcare, in my experience, when we see it happen virtually and when we see it happen in person, it's inspiring, and it does start to dissolve some of these unfortunate barriers that we've created for between each other.
That's right. It seems like we've got a lot of excitement. This isn't a question, but a lot of excitement about your healthcare graphic, Fran, which some folks are calling the healthcare faucet. But in addition to the wonderful graphic, we've got a question from a participant saying, how do we talk to folks who don't have a faith tradition or whose beliefs don't align in an attempt to make this issue important for them?
Well, again, or Fran, do you want to start us off on that?
No, go ahead, Ali.
You know, again, This is part of what's valuable and incisive about having global commitments to human rights that are grounded in international law. This is communities across cultures, across religions, traditions, and national boundaries agreeing together on some basic fundamentals of what all human beings deserve. So it doesn't require faith to believe in human rights. And in fact, part of the effectiveness of human rights is that there was such wide agreement on just some basics of how all human beings should be treated. So there's a movement that has tremendous mainstream secular support, and there are all kinds of opportunities to connect with advocacy, human rights advocacy that are not like our respective organizations associated with faith-inspired advocacy. In fact, I'd say I think we're in the minority in connecting faith and human rights, but the mainstream movement is much more secular, and so no barrier there to coming from a humanist or other perspective.
Well put by Ally, and I will say that that's my experience too, that we are in the minority. There are a lot of terrific groups, specifically in the US. Most folks who are arguing for a universal healthcare are doing so through a Medicare for All lens, which our organization also believes is the appropriate path and the most affordable and effective path. But you see National Nurses United and nurses organization obviously is really working hard on this. Physicians for a National Health Plan has for decades now worked very hard on this. So sometimes folks will do it through the healthcare provider lens. And of course, there's a significant moral authority that someone has when they're on the front lines actually providing the care. We admired the folks in that community 2 months ago. We admire them, and of course, even more indebted to them now. And if folks come from that or have family that are connected to healthcare providers, there are organizations pushing for. There's a lot of secular organizations pushing for universal health care, many of them through the Medicare for All prism.
Here's a really interesting question that I'll pose to you first, Ally. The questioner says, since many of us have investments that include different aspects of healthcare, what considerations should we keep in mind if we want our investments in healthcare to always lean in the direction of justice? And similarly, what questions should churches be asking regarding their investment portfolios in order to support a just healthcare system?
I mean, there are so many issues for justice-conscious investors to be mindful of, and one, I think, data point to be really curious about, and I'm kind of taking this from what I've learned from Fran in recent weeks. What are the profit margins of a company or an industry that is in one's portfolio? And if profit margins are exceedingly above other industries, as I understand they are in the pharmaceutical industry, that really demands attention as to why. How could you have such outside profit margins? But this is really Fran's area of expertise.
So I would just refer folks to this terrific organization called Interfaith Center for Corporate Responsibility, ICCR. And ICCR takes a shareholder position to try to affect change that's consistent with our faith's moral values. And so ICCR does address some of the issues that Ally brought up. They will purchase and hold as pension funds or what have you, ownership, shareholder interests in pharmaceutical companies, in large health insurance companies, and then deliver the message at shareholder meetings from the inside of the organization to say that, we have a moral obligation, maybe some profit, but not this much profit, maybe a CEO salary that allows them to live comfortably, but not $84 million a year. Let's make sure that our profit margins on insulin that's manufactured for $5 a vial doesn't charge $300 a vial. And so, yes, that's a really powerful combination that they've come up with both faith communities and investors. And of course, that was a really critical role in undermining apartheid, right? Is that the shareholder and oftentimes faith-motivated shareholders' investment saying, you corporations, we're going to expect you to behave in a moral way.
Yeah, go ahead, Fran.
the organization, again, is Interfaith Center for Corporate Responsibility. I assume it's something like iccr.org. But and again, a lot of denominations are a part of that and are trying to morally and ethically invest their resources.
Thanks for that, Fran. We've got about 5 more minutes in this session. I am mindful of the time. And before I sort of wrap this up, I want to invite Allie or Fran if they want to give any closing remarks, maybe 30 to 45 seconds each before we wrap this up for the afternoon. Allie, let's begin with you.
Thank you everyone for being here today. Thank you for your attention to this issue. It's a vital one, and we're seeing it played out before our very eyes. We're seeing that understanding a universal human right, this is not an academic question. We can't afford to treat it as one, as Fran has illustrated in such a compelling way. There's a real human cost to not respecting and protecting human rights. So I want to thank you for being interested in this topic and invite us all to continue learning more about how our faith or other belief system leads us to be an advocate for human rights.
Thank you, Allie. Thank you, Derik. I would just add that I really do believe we're at a tipping point. This is it's a horrible time. It's a scary time, but this is an exciting time because when crisis occurs, it's sometimes what it takes for really big change to occur. And many, many people in this country are very painfully aware today of our healthcare crisis in a way they weren't 2 months ago. So we have an opportunity to make a multi-generational change in our healthcare system for the better. And I think there's no question the faith communities are going to need to be a really important part of that. That's what history shows us. Faith communities and faith advocates are already a part of the process now. So I'd encourage folks to connect with your social justice committees of your congregation. Talk with the folks in your community, in your neighborhood, in your family. If you want resources, if you want help, Justice Revival and Faith in Healthcare stand ready. Send us a question. Send us if we can help, reach out to folks and help you with the process. But if we start talking to people and we start organizing, I think that we can get universal healthcare in this country finally, and it just may be the right time right now.
Thanks for that, both Allie and Fran. Finally, many of you are requesting resources and the PowerPoint and graphics. We are posting in real time many of those resources in the chat box. We invite you to go to those links to download that information. And we also want you to stay in contact with both of these organizations and both of these experts. It would be a wonderful thing to see these groups in your communities. So stay in touch with both Justice Revival and Fran's group. Finally, I think it's appropriate to end with one of our participants' comments earlier in our webinar, quoting William Sloane Coffin, saying, "The world is too dangerous for anything but truth, and too small for anything but love." We thank you all for your time today, and we hope to see you again sometime real soon. Thank you.
Thank you all. Thank you.
On behalf of Justice Revival and Faith in Healthcare, thank you.